go on to our next speaker, Dr. Gulshanjit Singh, who is going to be speaking about varicose vein, the principles of varicose vein treatment.
Good morning, everybody. I'll be speaking on general principles of the varicose veins. The varicose veins are the veins that have become distended over time, long, tortuous, and dilated veins of the superficial varicose system due to the pooling of the blood in the lower extremities. The term commonly refers to the veins on the leg, although it can occur elsewhere. The annual incidence is 2%, lifetime prevalence is 40%. It is 2 to 3 times more common in the women, and 10 to 20% actually are symptomatic who seek treatment. The etiology is primary 95%, secondary 5%. In the primary, because of the prolonged standing, violent muscular efforts, aging, obesity, OCP, and HRT, and secondary can be due to pregnancy, abdominal or pelvic tumors, chronic constipation, damage to the valves because of thrombophlebitis or thrombosis, and arteriovenous fistula. Now come the venous anatomy of the lower limbs. Is the greater saphenous vein is located along the medial aspect of the extremity. True duplication occurs in 10 to 37%. The saphenous nerve is present alongside, and the vein is present in the saphenous compartment, which on ultrasound looks like in the transverse section Egyptian eye. Joins the common femoral vein at fossa valis, known as saphenofemoral junction. A small saphenous vein travels with the sural nerve along the lateral aspect of the leg, joins popliteal vein at cephalopopliteal junction between the two heads of the gastrocnemius muscle. It may extend into the thigh and communicating with the femoral vein or GSV, known as vein of Giacomini. A true duplication is rarely reported. The perforating veins penetrate the deep fascia, tributaries of the saphenous vein, and the valves are located just distal to the penetration of the deep fascia. The venous veins cross the deep fascia obliquely, and the muscle contraction causes the valves to close prior to the venous compression so that the blood is forced proximally by musculovenous pumps. The veins are subcutaneous veins when abnormal. When the size is more than 3 millimeter, they are known as varicose veins. When the size is between 1 to 3 millimeter, they are known as reticular, and up to 1 millimeter known as spider or telangiectasia veins. The vein physiology is by pumps or valves. The muscle pump is also known as peripheral heart. The contraction propels the blood toward the heart. Relaxation draws the blood from superficial veins and lower deep veins. Factors helping in the venous return are negative pressure in the thorax during inspiration up to -6 millimeter, calf muscle pump, normal venous pressure in the relaxed state 20 millimeter of mercury, rises to 80 to 100 millimeter of mercury during the muscle contraction. Visat ergo is arterial pressure transmitted to the venous side through capillary bed because of the competent valves, and another is vena comitans lie by the side of the artery, helped by the arterial pulsation to propel blood. The perforators are ankle perforators, in the lower leg, cocket perforators 1, 2, 3, the boiled perforator below the knee, dot perforators and Hunterian perforators are in the thigh. What about the venous valves? The venous valves are abundant in the distal lower extremity, and number of the valve decreases proximally with no valves in the superior and inferior vena cava. They are delicate structures and prevent the reverse flow in the veins. These ensure that the blood is pumped from superficial to deep venous system and back toward the heart when the patient is in walking. This is just diagrammatic representation showing a normal vein and a reverse blood flow due to the damaged vein, which leads to the dilatation of the veins. A classification. The SEEP classification from the American Venous Forum 2004. In the clinical is C0, no visible or palpable signs of the venous disease. C1 is telangiectasia or reticular veins. C2 is varicose veins. And C3 is edema. C4 is pigmentation or eczema. And C4b is lipodermatosclerosis or atrophy blanchi. C5 is healed venous ulcer. And C6 is active venous ulcer. S stands for symptomatic and A stands for asymptomatic. Then we come to the etiological classification. It is E congenital, EP primary, ES secondary. Anatomical classification is AS superficial veins, AP perforator veins, AD deep veins. And pathophysiological classification is PR a reflux, PO is obstruction, and PRO is reflux and obstruction. A patient assessment. History of the symptoms and the onset of the disease, history of venous complications, desire for the treatment, comorbidities, rule out secondary cause including DVT, come to the examination, signs and symptoms. The aching and heavy legs, appearance of spider veins, ankle swelling, a brownish blue shiny skin discoloration, which lead to the status dermatitis, eczema, and may present with the bleeding. A skin above the ankle may shrink, lead to lipodermatosclerosis, a restless leg syndrome in patients with varicose veins, and other chronic venous insufficiency. White and irregular scar-like patches, atrophy blanchi. The complications, extremely painful ulcers, particularly near ankles, more on the medial side. A brownish pigmentation usually precedes the development of an ulcer, bleeding, superficial thrombophlebitis. This is showing brown pigmentation and venous eczema. This is showing venous ulcer just above the medial malleolus. This is showing lipodermatosclerosis and venous ulcer as well on the same side. The diagnosis is based primarily on the characteristic appearance of the legs when the patient is standing. Various tests are done to clinically correlate the disease, and investigations are helpful in the establishing a diagnosis. Various investigations are Doppler ultrasonography, duplex imaging, ambulatory venous pressure studies, and venography. Out of this, a duplex ultrasound is the most important, which helps to accurately detect the cephalofemoral reflux in the groin. Visually demonstrates the venous reflux into the superficial and deep veins. The degree of the venous reflux can be assessed. It can detect the incompetent perforators. The color reflects the direction of the flow towards or away. And normal direction of the venous returns without straining is seen on the left side, and on the right side we can see the reflex into the GSV with arrest of flow while straining in the femoral vein. The duplex imaging, this is the most important non-invasive investigation. It produces high-quality pictures using a combination of B-mode imaging and Doppler ultrasound. Anatomical, physiological, and functional details can be obtained. A venous lumen, flow, direction, and reflux of the blood can be accurately visualized. The site of the perforator incompetency can be located with great accuracy. It is useful in mapping of the saphenous vein before venous ablation, and duplex scan can be practically replaced venography for the assessment of the varicose veins, DVT, and chronic venous insufficiency. Now, to conclude, clinical assessment of the varicose veins in the patient is very important. Duplex ultrasound scanning is firmly established as the gold standard measures for assessing the preoperative mapping of the varicose veins, tributaries, and perforators along with the venous reflux. This helps to decide the treatment modality considered most appropriate for the patient. Thank you.
Thank you very much, Dr. Gulshanjit Singh. And now we have the last talk by Dr. Fraser. He's going to be talking about venous seal procedure.